Hi, everyone. This is Professor Cruz, and we're going to be touching up on, or going over, I should say, fetal heart tracing and how to read them. Now, this is a very, complex discussion, so I'm going to try to keep it very brief and lighthearted so that you can just get the grasp of it. If you go ahead and decide to become a labor and delivery nurse, hopefully, then you will definitely get some in-depth training. But this is just an overview, especially when it comes to NCLEX style questionings and how to do that. Okay, so let me go ahead and get that started. Okay, so when we are reading a strip, there's a couple things that we need to keep in mind. Okay, so an accurate fetal heart rate assessment may help in determining the status of the fetus and indicate management steps for a particular condition. In order to accurately assess a fetal heart rate pattern, a description of the pattern should include qualitative and quantitative information in the following 5 areas. So, first thing you need to know is a normal fetus heart rate is between 110 to 160 beats per minute. Okay. When we're looking at the heart rate, one of the main things that we look at is their variability. All right. So, variability, we would describe that between absent, minimal, moderate, or marked. And we're going to discuss that in the next few slides. We also want to look for accelerations. And depending on the amount of weeks gestation our fetus is, we are going to either look for a 10 by 10 or a 15 by 15 acceleration, which again, we're going to discuss in the next few slides. We're also going to be looking for decelerations, and that could be either variable decelerations, early decelerations, or late decelerations. And we're also going to be looking at the trends and changes of the fetal heart rate patterns over time. All right, stay with me. A lot of information, but we'll get through it. All right. So when we're talking about variability, okay, we are looking for fluctuations in the heart rate of 2 cycles per minute or greater baseline variability. And so we would describe the variability as absent, minimal, moderate, or marked. Now, we always want to see moderate. That is the normal, that is what we are looking for. And absent is absolutely what we do not want. Minimal or marked as well. Okay, so we want moderate. So let me show you what those look like. Okay, now this is a monitoring strip. Okay, now when you look at a monitoring strip, you have to understand that the bottom part right here, where I'm circling with my mouse, these are contractions. Okay, so we're not really focusing on contractions right now, but just so you know what the difference is, just think of the baby is on top of the mom. So up here is the variability monitoring strip, what we're looking at. So the first thing that you need to know is that each box here represents 10 seconds. So 1, 2, 3, 4, 5, 6. Between the red lines is 1 minute long. So again, each box represents 10 seconds. Okay. Now, these grooves right here is what we want. We do not want to see smooth lines on our fetal heart tracing monitor. Okay. With these fluctuations, the ups, the downs, the grooves, those are very good indicators that our baby is well oxygenated and that is doing well. Okay. Now take a look at this next slide. And so absent would be almost nothing, undetectable. You won't see any grooves, you won't see any fluctuations. We do not want this. Okay. If we are seeing this on the fetal heart tracing monitor, we are panicking. Okay. We want to know what is going on immediately. Minimal, there's a little bit more ridges to it. Moderate is what we want, okay? And this is between 6 to 25 beats per minute in fluctuation. Now, remember I told you that each box represents 10 seconds, okay? And then marked is when there's a greater than 25 beats per minute that has jumped from the baseline, okay? Now, just so you know, in the normal fetus, okay, there is an interplay between the sympathetic, which is what we would call an acceleration, and the parasympathetic, which would cause deceleration, which would be a decrease in the heart rate. All right, so those nervous systems control the heart rate. These systems exert their control, via the cerebral cortex, the medulla oblongata, the sympathetic ganglia, and the vagus nervous system. So the interaction between these systems results in the difference in the beat to beat intervals, resulting in variability of the fetal heart rate tracing. So in the full term fetus, okay, moderate variability is considered normal because it indicates a normal functioning central nervous system. All right. So conditions that alter the integrity of this neurocardiac axis, such as hypoxemia, would result in the loss of heart rate variability. Okay. So variability is the single most important indicator of an adequately oxygenated fetus. So, in other words, we want to see variability. Okay. We want to see the grooves and the ups and downs that are within the normal limits. Anything outside of that, there is something going on with our fetus that we need to figure out. We don't want absent because absent tells us that there's not a lot of perfusion going on. Okay. Minimal, when we see a minimal variability, we would have to, look a little bit further as to why. It could be the fetus could be sleeping and they do go in 20 to 40-minute sleep cycles. So sometimes, we'll give the mom a cracker or some juice, or we'll switch the mom's position and see if that changes the minimal variability. Okay. When it comes to marked, and if we see that over a period of 10 minutes where we're seeing such a high jump, that could mean acidosis in our fetus. So we'll discuss a little bit more about that in a second. All right, so moving on. Now, when we're talking about variability and decelerations, you need to know that there are three types of decelerations. Okay, we have early deceleration, which is the one right here. We have late deceleration, and then we have a variable deceleration. Okay, now variable decelerations really go back to the baby's cord. And what I mean by that is, let me actually show you something. Uh, Give me 1 second. So before we actually go there, let me move up a little bit and just tell you first about acceleration. So acceleration is when the heart rate jumps at least 15 seconds up and 15 seconds across. So actually, I think the first slide might have been a little bit better. So this one right here. So let's talk about an acceleration. An acceleration is a jump of 15 seconds up and 15 seconds across. So I told you that each of these boxes represent 10 seconds. So if I tell you that we are looking for a 15 by 15 acceleration, I'm talking about the length between 1.5 boxes up and 1.5 boxes across. So the baseline is the average of the heart rate within a 10-minute strip. Now, I told you that between the red lines is 1 minute. So this is 1 minute, 2 minute, 3 minute, 4 minute, 5, 6, 7, 8. So this is an 8-minute strip. Okay. Now we are going to see how the heart rate goes up. It'll have a little drop. It goes back down here. It goes up again and then it comes back down. So as you see, even if it goes up or down, it normally will resolve back to a baseline. And as you can see, this one goes up and then it comes back down, goes up, comes back down. So the baseline for this one right here, I would say is 150. Okay, because even though it does have its jumps, it comes back down. It goes up and it comes back here. So the baseline for this particular strip is 150. Okay. Now, when we talk about accelerations, we are talking about from 150, right? Because that's our baseline. And it jumps at least 1.5 boxes up. Oops, sorry. I clicked on something. We are talking about 1.5 boxes going up and 1.5 boxes going to the side. Okay, so if the baseline is 150 and we see that it goes all the way to 180, that already passes 15 beats going upwards. And this has at least 1.5 going across. So this right here is an example of an acceleration. Okay, an acceleration. Now, looking here, does this look like an acceleration to you? No, it's not an acceleration because the baseline here at 150, it only goes up a little bit and goes across. It's not a big enough, acceleration to be considered an acceleration, if that makes sense. We do love that this is has a lot of grooves, that it's going up and it's fluctuating, but an acceleration would be something like this, okay? Even something like this over here. Okay, so these are considered an acceleration. And this is important because when we are talking about a non-stress test, an NST, we are looking for two accelerations in a 20-minute strip. And we'll discuss that a little bit as we go on, as we further on. But that is what we're looking for. We love accelerations. Accelerations tell us that our baby is happy, well oxygenated, and that our baby is thriving. So when I see a strip like this, I am very happy. This tells me our baby has moderate variability. It has many accelerations. Okay. And this is a good strip right here. So I wanted to show this to you first before I show you the decelerations, which is when there's a drop in the heart rate. All right. So we're going to move past a couple slides here. So let's talk about decelerations. Okay. So we have three types of decelerations here. We have an early deceleration, a late deceleration, and a variable deceleration right here. Now let's talk about the early deceleration. An early deceleration is the deceleration that mimics the contraction. So down here, these are our contractions, okay? An early deceleration is when the heart rate drops at the start of the contraction and it comes back to normal by the end of the contraction. So pretty much it's mirroring the contraction. Now, I want you to remember this. It's always good to come early to class, and it's not good to come late to class. What I'm trying to say is an early deceleration is not something that I would freak out over if I am the nurse and I'm monitoring this patient. The late deceleration is the bad one. So, early deceleration is when the fetal heart rate is mirroring the contraction. Now, why are we not worried about this? Well, this tells me that every time mom has a contraction, the baby is trying to come down, is trying to come out, which is what we want in labor and delivery. Well, when a patient is laboring, the contractions is what's pushing the baby down. Okay. So this tells us that every time mom has a contraction, the baby is trying to come down, okay, which is trying to come out. So if I see this on a monitoring strip, I'm going to go into the patient's room and I'm going to try to do a vaginal exam to see if mom has, progressed further. Maybe she was at 4 centimeters dilated. And now that I see all these early decelerations and with that, compression and a lot of those contractions, maybe she has progressed from 4 centimeters dilated to maybe now she's 6 or 7 centimeters dilated. So when we talk about an early deceleration, I'm not worried about it. I'm going into the patient's room. I'm doing a vaginal exam to see if mom has progressed further. Again, it's always good to come early to class. It's never good to become late to class. Okay. Now, moving on to the next one. I'm going to skip the late deceleration for now and move on to a variable deceleration. So, this is an example of a variable deceleration. And a variable deceleration can either look like a V, a U, or a W. And a variable deceleration doesn't necessarily correlate with a contraction, but a variable deceleration is a cord compression, which means that the baby is on the cord and it has stopped oxygenation to the baby. So in case you don't know, the placenta is what gives the baby oxygen, nutrients, everything that it needs. Okay. So whenever the baby is in a position where it's cutting the cord or is on the cord, it's going to have a sharp down and bounce back up. Okay. It's going to be a quick motion. It just says that, the baby is on the cord or that there's something going on with the cord. So if I am seeing variable decelerations on the strip, I'm going to go into the patient's room and I'm going to say, oh, it looks like the baby is not in a good position right now. The baby doesn't like this position. Let's move you to the other side. And that way we help the cord and we are not having the baby press on the cord. Okay. So when it comes to a variable deceleration, okay, we are just going to change mom's position because it is a cord compression. Okay. Again, a lot of information, but just bear with me. I promise we'll get through this. All right. Now, the next one we're going to talk about is a late deceleration. And a late deceleration is not good. Okay. We do not like late decelerations. So, a late deceleration is when mom has a contraction, and at the peak of her contraction, the baby's heart rate starts to drop. And it takes a while for it to get back to its normal heart rate. Okay. Now, this is a sign that the placenta is not well, is not doing good. Okay. We know that when a mom has a contraction, I don't know if you know, but when a mom has a contraction, there is very little oxygenation happening to the fetus during that time. So when mom has a contraction, the fetus has to resort to the stored oxygen in the placenta. So, what does that mean? Throughout mom's pregnancy, over time, the placenta has stored oxygenation for the fetus to use during labor, pretty much preparing for the big day. Okay. Because we know that every time mom has a contraction, the baby stops getting oxygenation through the placenta. So it has to rely on the placenta for that stored oxygen. So if at a time when mom is having a contraction and the placenta is not oxygenating the baby, we know that the placenta is not a well working placenta. So a late deceleration, again, is when the heart rate starts to drop after the peak of the contraction. So remember, each box represents 10 seconds. So this is like about a good 1 to 2 minutes where our baby's heart rate is not in the norm. Okay. As you can see here, during an early deceleration, as soon as the contraction's over, the baby is at the normal heart rate. But with a late deceleration, it starts to drop at the peak of the contraction, and the heart rate is down, 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 and it's slowly coming back up, which takes a lot of time and it's very bad for our baby. Our baby's not getting oxygenation during that time. So when it comes to a late deceleration, this is not a good thing, and we need to alert the doctor immediately. Now, when we see a late deceleration, there are three things you have to do first before you call the doctor. And this is extremely important. So please listen. Okay. If we see a late deceleration, which looks like this, okay, it starts to drop after the peak of the contraction. The first thing you have to do, no matter what, is turn the mom on her left side. So let's say I see this late deceleration. I am running into the room and putting mom to her side. Okay, so if we and possibly the left side, which is what we want. Turn mom to the side, and then we're gonna give her oxygen, and then we're gonna give her a bolus, okay, of fluids. You have to do those steps first before you call the doctor. Now, if the mom is on Pitocin or oxytocin and we are seeing these late decelerations, then as soon as we walk into the room, we turn off the pump first, and then we put mom to the side, give her oxygen, and then we give her fluids. Okay? The main takeaway from this is that we have to put mom on the side first, because any NCLEX question that you get regarding a late deceleration is likely going to be discussing what you're going to do in that situation. So unless she is on oxytocin or pitocin and she's having late decelerations, you would turn off the pump first, and then you would put mom to the side. If the question does not state that she is on Pitocin or oxytocin, the first thing you do is put her to the side, and then you give her oxygen, and then you open up her fluids. That's the first thing you do. Those steps are the first things that you do, and then you call the doctor. And chances are the doctor is going to prepare for a C-section. And the reason why is because this is telling us that the placenta is not well. The placenta is insufficient, because in a normal, healthy placenta, a placenta can tolerate contractions. This is saying that with a contraction, the placenta is struggling to provide oxygenation to our fetus. It's struggling to thrive. So we're going to need to take that baby out as soon as possible. Okay. A lot of info, but I do have a mnemonic called veal chop that we are going to learn. All right. We've already seen this. We're going to come back to those in just a second. I really want you guys to take a look at this. And this is what's really going to save you when it comes to certain NCLEX style questions. Okay. So veal chop. Okay. And no, we're not talking about the dish. Okay. You're going to write VEAL like this, and you're going to write CHOP like this. So if we see a variable deceleration, again, it looks like a V, a U, or a W. Oops. Sorry. Hold on. Keep pressing that. If we see a variable deceleration, we know that it's cord compression. So we're just going to tell mom to move to another position because the baby's likely on the cord and it's causing, that disruption of perfusion to the fetus. If we see an early deceleration, this is caused by head compression. Every time mom is having a contraction, the baby is trying to come out. So all we're going to do is just do a vaginal exam to see if the mom has progressed with her, if she's progressed in dilation. If we were to see an acceleration, our baby is okay. We love accelerations. Those are jumps in the heart rate telling us our baby is well oxygenated. Okay. And then if we see a late deceleration, that means placental insufficiency. That means that the placenta is not working as it should. Okay. So if you see here, variable decelerations are associated with cord compression. Okay. So again, variable deceleration, it's pressing the cord. Early decelerations are associated with head compression. Okay. And this is generally a benign event, which means that it's nothing to be worried about. This is because the baby is doing what it's supposed to do. Every time mom has a contraction, the baby's head is compressing more, which means our baby is trying to come out. We're going to do a vaginal exam. All right. Accelerations are associated with oxygenation, and it's a pretty good it's a pretty good determination that our baby is doing well. All right. Now, late decelerations are associated with placental insufficiency. All right. So that means that our placenta is not working. So if you're going to take anything away from this video, understand the importance of veal chop and how you can determine the difference between an acceleration and a deceleration. Okay. Now, let's move on. All right. So we see here, we saw this strip a little bit earlier. We see here that we have a lot of accelerations, okay? And even when the mom is having a contraction, our baby is thriving, all right? Our baby is doing well. There's no decelerations, okay? Another contraction here, and our baby is doing well. Now, it looked like there could have possibly been a little bit of a cord compression here. But as you could see, with the variable deceleration, this is an example of a variable deceleration, it quickly bounced back, right? So maybe the baby laid on the cord for a quick second and got off the cord and it bounced right back up. That's a variable deceleration. With another contraction here, our baby is well oxygenated, the placenta is working very well, and our baby is happy, okay? Let's take a look at this one. And this one's a little bit harder to read, but I'm going to give you a second to look at it and tell me what you think. I want you to tell me, what type of variability is it? Does that look like an absent variability, minimal variability, moderate variability, or marked variability? And then tell me if you see any accelerations or decelerations. And I'm going to give you about 30 seconds and then we'll discuss. All right. And if you said minimal variability, you are correct. Okay. So we still have some grooves here, but they're not as big or as moderate as the one before that we saw. So this is a minimal variability. And we have to look at the contractions here. There's one contraction here, another one here, and another one here. Now, as you can see, every time mom has a contraction, there's a little bit of a deceleration, but by the time it finishes, it's back to the baseline. Same with this one. Look at this contraction here, and we see a dip that's mirroring it, and same here. So this is an example of an early deceleration or 3 early decelerations. We're not worried about this. As much as I would like a moderate variability, okay, we could also have some minimal variability due to medication or a sleep cycle. Okay, so those are some things to consider. Like I said, I'm not going to go too deep into this because it's going to be information overload, but I want you to recognize some types of decelerations. Okay, so this is an example of an early deceleration because it is mirroring the contraction. Okay, let's look at the next one. All right, now do you see any accelerations here? And what is the variability? What do you think? All right. So the variability that we have here is a moderate variability. Okay. As you can see the difference between the other slide I just showed you and this one, you can see there's a lot more grooves, a lot more spacing in between. Okay. But do we see any accelerations? No, we don't see any accelerations. Okay. Which remember, an acceleration is a jump from the baseline 15 beats by 15 beats. So it'd have to be 1.5 blocks going up and 1.5 blocks going across in order for it to be an acceleration. So these little grooves right here are just not big enough to be labeled an acceleration, but it is telling me that this is still a well oxygenated fetus. We have moderate variability, and we know that that is the most important thing that we're looking at on the strip. Okay, we could have a moderate variability and no accelerations and still be fine and still be a good strip. Of course, we would love to see accelerations because that just confirms that our baby is well oxygenated. But because the variability is the most important thing that we look at on a strip, we know that this is a good indicator that our baby is well oxygenated, even with the contractions that we see here. All right, what about this right here? What type of deceleration do we see, and what is the variability? And I'm going to give you a couple seconds to take a look at that. All right. So we have a minimal variability and we have a variable deceleration. Okay. Now, why do we have a variable deceleration? Think of veal chop. What can variable deceleration mean? A variable deceleration means that there is a cord compression. So as the baby is, in the mom's uterus, at some point the baby must have pressed on the cord, which will reduce oxygenation to our baby. So it quickly came down and it quickly came back up, which means that the baby probably moved and now it's back to its normal heart rate. Now, while we're talking about the heart rate or the baseline, what do you think the baseline is here? Well, we know that this is 150 and this right here would be 160. Now, it's kind of in between. One second. It is kind of in between the 150 and 160. So it's kind of in the middle. It's not exactly on the line. So we would say that the fetal heart rate would be between 155 and 160. But if I had to choose one, I would say 155. All right. So this is a minimal variability with a variable deceleration, with the fetal heart rate being 155 to 160. But again, if I had to choose one, it would be 150, 155. I'm sorry. Okay. And what about this? What is the variability for this one? This is what we would consider an absent variability. Okay, this is where our baby is in trouble. We need to go ahead and call the doctor immediately, and he will likely do an emergency C-section to get this baby out. This tells us that our baby is not well oxygenated. And this is a very scary thing to look at, really, when you are working on the labor and delivery floor. Okay, so this is what we would consider an absent variability. Okay. Now, just to kind of wrap up and um, discuss briefly on a non-stress test, okay, an NST. A non-stress test is the best way to look at our fetus and how they're doing. So let's say our mom has preeclampsia and the doctor has ordered for her to come to the labor and delivery unit twice a week until she delivers. And he wants her to do an NST, a non stress test. What they're going to do is they're going to have the mom, lay down. We're going to put the monitors on her. That we're going to put two Toco monitors on her. One monitor is going to look for the fetal heart rate, and the other monitor is going to look for contractions. Now, in a NST, we do not expect to see any contractions in our mom, okay? Because if our mom has preeclampsia and the doctor just wants to take a look at how the baby is doing twice a week, we're not expecting her to come in with contractions. So, this strip, just imagine if there was no contractions, because if we're doing an NST, our mom is just there so that we could take a look at the baby. So, we are not expecting her to have any contractions. So, do not pay any attention to my example right now talking about a NST because our mom would likely not have any contractions. So we're just going to be focusing this discussion right now on this. So when mom will come in, she'll lay down. We're going to put the two monitors on her and we're going to give her a clicker. It's like a little black clicker. And we're going to tell her every time you feel the baby move, I want you to click the monitor, to use the clicker. The clicker is just going to mark the page. And what that tells us is that every time the baby moves, we should see an acceleration. So it's just to mark the page. And so we're going to give her 20 minutes. And we want to see the baby have two accelerations in 20 minutes. So if I was to see this strip, I would say, yep, there's an acceleration here. And there's a couple more accelerations over here. And I would label this as a reactive NST. Now, before I could call the doctor and say, hey, doctor, just want to let you know this is a reactive NST, I would have to show one of the other nurses on the unit, and she would also have to agree with me and say, yes, I agree that this is a reactive NST. Once I get her okay and my okay, that's when you call the doctor. So you do need to have two nurses confirm that you have a positive, I'm sorry, not a positive, you have a reactive NST. Now, let's just say that we saw this. Okay, let's say mom lays down, we give her the clicker, and we are looking for two accelerations in a 20-minute strip. If I don't see any accelerations, I cannot label her as a reactive NST. I would give her another 20 minutes, which would give her a total of 40 minutes to see if maybe the baby was sleeping or just wasn't as reactive. And during the next 20 minutes, I would give her some chips, like some crackers, juice, um, ice chips, just to try to get the baby up. And we're still looking for two accelerations. If I still don't get two accelerations in a 20-minute strip, okay, or in the 40-minute total, I would have to call the doctor and say, hey, doctor, our baby has a non-reactive NST, and this is after 40 minutes. And then the doctor will likely order a biophysical profile or an ultrasound to figure out what is going on and why isn't our baby giving us two accelerations in a 20-minute strip. Okay. So to wrap up, when we talk about an NST or a non stress test, this is a way for us to look directly at the fetus and their well being. We're looking for two accelerations in a 20-minute strip. If we don't get two accelerations in a 20-minute strip, we're going to give her another 20 minutes with ice chips and crackers, and we're going to try to get that baby moving to give us two accelerations. If we still don't get two accelerations, then we'll call the doctor and he will then probably order an ultrasound to further investigate as to why our fetus does not give us an acceleration. Okay. Um, that pretty much wraps it up. It's a lot of information, and I'm just giving you the basics. Okay, so feel free to reach out to me or schedule a one-on-one with me if you want to learn more. But I just gave you an overall. There's many other components and details, but again, this is an 8-week program, and I just want to give you, the gist of it. So I really hope that that helped you. And if you have any questions, please book with me. Thank you.